Okay, well, so welcome to the inaugural program of FYIPD. We have Betsy Bierk, and I'm John Dean, and we're starting our very first call-in program about Parkinson's. We want to answer your calls. We had a couple people call our Google Voice number, and then we're going to ask the good doctor some questions of our own as well. And every month we hope to be interviewing a different physician and another expert in the field, and today we have Dr. Benzi Kluger from the University of Colorado. He's a movement disorder specialist. I'm trying to think of what we can say about Dr. Kluger. He's a patient favorite and a great presenter. He's got an interesting background with a master's in psychology, and it gives him an interesting perspective. But Betsy, what do you want to say about that?
He speaks in plain language. He explains complicated subjects with a lot of humor and in a way that people can understand. And he'll take any question.
Yeah, that's the other thing.
Which is making him very popular.
He's kind of fearless in that respect.
He's fearless, yeah, but practical at the same time.
So without further ado, I think we're going to put you on here, Doctor, and we'll start with some of the questions here.
All right, sounds good.
Anything you want to add to that, Benzi, before we get started?
I don't think so. I'm ready for some questions.
Yeah, well, we got a couple of those. So I'm just going to switch to a bigger screen, and
there we go.
There we go. So Benzi, I guess the first thing we want to know is, can you give us an explanation of what non-motor symptoms are? What does that mean?
Sure. So non-motor symptoms is really refers to any symptom that people with Parkinson's disease have that does not involve the motor system or the system that controls movement. So that would include things that affect thinking and memory. That would include mood. That would include pain and sensory symptoms. It also includes symptoms that involve the autonomic nervous system, such as constipation, problems with bladder, problems with erectile dysfunction. So really everything except for tremor, slowness, stiffness, and balance would fall into non-motor.
Okay, and it's interesting that we were talking about this before you got started. So do you divide the kind of components of a non-motor problem into things that would be covered by the autonomic system versus some of the other components, cognition or something like that?
Yeah, I think the term non-motor, there is probably 5 times more non-motor symptoms than there are motor symptoms. So I think it is useful to kind of divide it up into different key areas. So I think autonomic would be one, sleep and energy would be another, thinking and memory would be one, mood would be another, and then sensory pain, and then there's 2 other oddball things that you could throw in there.
Interesting. Yeah, pain is a really interesting topic. Right. Can we ask a couple questions about that? What do you notice when you have someone that has pain and you're trying to determine whether it's Parkinsonistic or it could be related to something else?
Sure. So with the evaluation of pain, there's kind of 2 sides to it. So it's one side to it, which I think is important for patients and also physicians to know, as I think there's a little bit of a mythology out there that Parkinson's does not cause pain.
Sure is.
And there's a lot of evidence that Parkinson's often has pain. Probably about 75% of people with Parkinson's will experience some kind of pain.
Wow.
Sometimes pain can be the first symptom and precede other recognizable symptoms. So it's not uncommon that someone may come to see me who's already had neck or shoulder surgery, which are 2 common areas where you get pain, and it's only later that we find out that it's from Parkinson's. So one of the ways, that I look at pain is, does the pain fit a classic pattern for Parkinson's? Does it fit the side of the rest of the motor symptoms? Does it seem to respond to Parkinson's medication? And some of the kind of common things that we see with Parkinson's pain, some of the ones that are easier to see can be dystonia, where people have abnormal muscle contractions, and then you can visibly see the muscles contracting and cramping. Often involves the hand or the toes, and it's very classic for Parkinson's. Some of the ones that are trickier could be like pain in the shoulder or pain in the neck, where the can be seen with Parkinson's, but it's also common in other older adults. And then it becomes a little bit more nuanced, and part of it's how people respond to treatment, and part of it's kind of the time course of the disorder. So if people really didn't have any symptoms before, they all of a sudden have shoulders pain out of the blue, and they have some other subtle motor symptoms on that time, and most likely they are related to Parkinson's.
Got it. And you were talking about dystonia before, right? With either facial or with I see a lot of times in people's foot or in maybe their calf muscles. Is that possible? Or
yeah, the most common is probably the foot and toes. The calf is pretty common. Sometimes people have it involving their hand. And sometimes people can have it involving their neck. They can have it's known as torticollis or cervical dystonia, so they can have abnormal tension in their neck or twisting or turning and causing them pain.
Dr. Kluger, could you explain what dystonia is?
Yeah, dystonia means that people have an abnormal contraction of muscles. So even when they're trying to relax, their muscles are not relaxed. And so, for instance, involving the foot, it could be that their big toe is being pulled up, their toes are being curled in, that they're having a Charlie horse in their calf, that their hands kind of curled in, and it's hard for them to get it to relax. So those would be all examples of dystonia.
And how do you treat dystonia?
So usually the place I would typically start is with regular Parkinson's medications, so things like Mad and Dopamine. And if those are not helpful, there are some specific medications that can help with dystonia. Sometimes magnesium, just over-the-counter magnesium, can help with calf cramps, particularly when they're at night. Botox injections is something that we sometimes use. Quinine, which is in mineral water, can sometimes be helpful for nocturnal cramps. So those are all kind of places to start with. Sometimes we use other pain medications and muscle relaxants.
Just recently I was doing some work down in Arizona, and I came across somebody who seems that the more that we would work with this individual, the more pronounced it was like an internal foot inversion. It's like it became an exercise-induced dystonia. Do you see that very often?
Yeah. So there's a few different patterns that we see with dystonia. Probably the most common is that when people first wake up in the morning, they notice dystonia. And that's usually a result of their medications wearing off from taking it the night before. And sometimes taking a long-acting medicine at bedtime helps prevent that in the morning. People can also have off dystonia during the day, whereas their doses wear off, that they get the dystonia. But there are people who are just like you described, who seem to have more exertional dystonia, where it really doesn't bother them unless they're walking or moving or running, and then the cramps tend to come out more. And sometimes if people know they're going to be doing physical therapy or something like that, they can take like an extra half a Cinemet. Sometimes I'll talk about this as a trick. At other times, take a half Cinemet, crush it in orange juice, and orange juice helps to get absorbed faster, and then that really helps them get through their workout.
I've heard that the vitamin C does help with absorption, and another thing I've heard is carbonated liquids improve absorption. Is that true as well?
Yes, it is. Particularly things that are acidic, like Coca-Cola, for instance.
Okay, not just seltzer, but something with the acid. Okay, well, where do you want to go with this next, Betsy?
I have a question about dual tasking and what happens, and it's a very common complaint among people with Parkinson. It seems to get worse over time.
So difficulties when you're dual tasking? When
you're trying to do one thing, and then you add something in, and you drop the first thing you're doing, you can't do two things at the same time. And then the idea of weeding out distractions on top of whatever the task is.
Right. So that would fall under some of the cognitive impairment that people with Parkinson's see. So there's when we talk about thinking and memory, we can divide it up into different areas. So one area is memory, one area is language, one area is visual and spatial, one is attention, and one big area is what we call executive function. And executive function includes people's ability to multitask, It includes people's ability to keep a phone number in their head. It includes their ability to deal with distractions, to be mentally flexible. And in Parkinson's, even in very early Parkinson's, a lot of people will have problems with executive dysfunction. And we're not exactly sure why that happens. One theory has to do with something called bradyphrenia, or slowness of thinking. So the idea would be that if you're slower with your thinking, just as you are slower with movement, that it's hard to keep multiple things up in the air at the same time. Kind of like it'd be harder to juggle if you were slower. Another thing, which is an area that I'm doing research in, has to do with what's called cognitive reserve, which is kind of basically how much backup or extra, RAM, if you use a computer analogy, but how much extra memory storage capacity that your brain has. And so in people with Parkinson's disease, that seems to be less than in people without Parkinson's disease. And so some of the consequences of that is that it's very hard to deal with distraction. Mental fatigue is much more of an issue. And that when people are dealing with something else, for instance, a bladder infection, pneumonia, a different kind of medication, that sometimes it's more easy for them to become confused, again, because they don't have as much backup or enough wiggle room before they begin having thinking and memory problems. The other thing I will say with that's important is that there's been a lot of research lately about kind of walking and talking as a form of dual tasking, and that there's an increasing amount of evidence that falls in people with Parkinson's disease may in part be due to changes in thinking and memory and related to people's inability to maintain focus on two things. And so, it may be worthwhile to not try to talk on the cell phone a lot, and to really kind of stay focused on one thing at a time. And it seems to help even with breathing, that if people are able to maintain their attention and use more of their mental faculties, that they may be able to walk better and avoid falls.
What about driving? Is that affected?
Yeah, so driving is a big topic. There's a number of things that can affect driving in Parkinson's. So one of them is vision. So one of the non-motor symptoms in Parkinson's disease is vision. And in particular, people's ability to see subtle shades of gray. So it particularly can affect night driving. Thinking and memory problems and judgment can be involved, reaction time and slowness. That being said, a lot of people with Parkinson's can drive perfectly well. So usually when somebody asks me about driving safety, I ask them that they have concerns, because that can be a sign that, maybe we need to do more, or if their spouse is driven with them, if their spouse has concerns. And if either the patient or the spouse or myself have any concerns, what I'll do is I'll have them go to either AAA or quick rehab or another place to get on the road driving testing. And that's really critical because you don't want to be in an accident for legal reasons. You don't want to hurt somebody's kid who runs in front of you on the road. You don't want to hurt yourself. And so I think anywhere from $100 to $400 that you would spend for getting the official driving testing is well worth it.
Yeah, I think the driving issue, it's very loaded because of the loss of independence. But I think you're right to send them to somebody to do it. Like I think North Suburban does do that evaluation as well, North Suburban Hospital, and it does end up kind of taking it out of what your spouse might be saying or what you can observe in a treatment room, and really makes it a lot more. I don't know. I'd say standard. I can't take that away. So yeah, I think that's a great idea. And I'm interested, though. I think you brought up the driving as far as distractibility. Do you think that the bradyphrenia that you were talking about before could lead to more distractibility in the car?
Yeah, definitely. So the thinking and memory and executive dysfunction is definitely one of the factors that can affect driving. And so when I'm seeing somebody with Parkinson's disease, the things that would make me concerned, would be one, if they have, severe visual problems or visual spatial problems. Two, if they have, significant slowness of their limbs, so I feel like their reaction time and their ability to react to things happening on the road are going to be affected. And then the last one is thinking and memory problems. So if people do have executive dysfunction, if they have, particularly if they have dementia, but even if they have mild cognitive impairment, that can, kind of raise my concern for their ability to drive safety. And one of the things that I do tell people because, this is such a driving culture, driving's tied to independence, is that, in a perfect world, I'm sure you could drive to the grocery store, you could drive to your daughter's house, whatever, but unfortunately we don't live in a perfect world. We live in a world where kids run in front of cars, where there's dogs, where there's construction, and that we need to make sure that people are safe under all circumstances, not just under their routine circumstances.
There you go.
That's a pretty tough conversation to have with the patient. Do you have patients accept that pretty readily because it's coming from you, or what do you do about it?
So one, I would say the majority of the time, I'd say probably 90% of the time, when I frame it in terms of, one, that they're putting themselves at a lot of legal risk by not getting tested, and that, two, when I put it in terms of, them hurting somebody else's kid or hurting themselves, that, people can usually accept that it's probably a worthwhile investment to get the testing. And most people are okay with the testing. Sometimes I may have significant enough concerns that I will tell people that they really shouldn't drive. And if they really insist on it, then I'll have them get tested. But in some people, usually the way it works is that somebody has dementia and they have poor insight. In those situations, it can be pretty tricky, and sometimes we will kind of be in cahoots with the caregiver and hand the key, or get rid of a car and things like that. Because our primary responsibility is to keep the patient safe and to keep the people around them safe. And I'm okay being the bad guy and making sure that the husband or the wife or the son is not the bad guy.
I think that's a very salient point at the end there, Doc, which is that you should be relying on the medical professionals to be
help you.
Having those conversations that maybe if you have them, it's going to have a real impact on your relationship. So please offload that to the doctors, because they're the ones that can really speak with the authority. I want to take it one step further. You talked about bradyphrenia. We got a couple calls from Kirk Hall, the author of the Carson and Shaky Paw's Grandpa, and now he has another book called Window of Opportunity, where he talks about his concerns about mild cognitive impairment. And can you delineate kind of where it starts at bradyphrenia, which is the slow processing, and then you have the mild cognitive impairment, and how that may progress to a Parkinson's disease dementia? And Kirk did want me to mention to say thank you for writing the forward for that book. You really appreciate your help.
Yeah, sure. It's a great book, and you're reading the forward. I remember when it was just an idea in Kirk's head, and I really encouraged him to do it, and I was really pleased that he stuck with it. But anyway, the distinctions that we make in terms of thinking and memory is, one is normal aging. So the first thing that I think everyone needs to know is that after age 25, everybody's thinking and memory will slow down to some degree. And so, that's just part of growing older, and sometimes people will, come in telling you everything that they forgot over the last month, and that's not dementia, that's not even mild cognitive impairment, that's probably just normal aging. Mild cognitive impairment, which is very common in Parkinson's, even at the time of diagnosis, maybe about a third of people, sometimes more depending on how you test for it, will have mild cognitive impairment, which means that they have more thinking and memory problems than we would expect for somebody their age, but not to the point that it's dementia, so that they have thinking and memory problems, but it's not reached a degree where it's impairing their ability to care for themselves. And so having problems with dual tasking, multitasking, having problems where you're not finding words as readily, that you're finding yourself going into rooms more frequently and not remembering what you needed to do. But all that could fall into mild cognitive impairment if it's really to a greater extent than we would expect in normal older adults, but it's not dementia. And then dementia means that you have problems with thinking memory that are so severe that you're no longer able to care for yourself adequately. And so, for instance, interviewed on TV and radio about Pat Bolin, and so, he had reached the point, where he was no longer able to manage the Broncos. People can reach a point where they can no longer take care of the bills, where when they're driving they get lost. When they're thinking memory problems, reach a point where it really impacts their safety, for instance, leaving the stove on repeatedly. And then it can progress a lot further where people, can even forget, their loved ones. And so, a lot of times people will come in with concerns about dementia. Most of the time, if people are concerned about it, they don't have dementia because they're still able to take care of themselves. And so a lot of times that's reassuring. But as Kirk mentions in the book, mild cognitive impairment can be a precursor or can increase your risk for developing dementia. And so it's kind of a key window to try to intervene. We're actually doing a study right now at the university, and I don't know if you're going to send out my email address or anything like that, but people who are interested in taking part in research involving thinking memory can contact me. Actually, my email address should be freely available on the web through the University of Colorado website. You can just send me an email, and we have a study where we're trying to use a particular type of magnetic stimulation to try to improve thinking memory, and the long-term goal would be to really try to prevent dementia or to make thinking memory problems a treatable symptom just the same way that tremor and slowness and other things are treatable symptoms.
That's great.
That would be amazing.
That was truly.
Is it possible that, and I don't know quite where I'm picking this up from, that there are people using DBS for treating memory issues?
Yeah, there is a trial that's currently ongoing for thinking and memory using DBS and Alzheimer's disease. And that trial, like a lot of things in medicine, came from an accidental discovery where a group in Toronto was doing DBS for weight loss. And I don't believe it's been super effective for weight loss, but what they found was that the people who were getting DBS from weight loss reported that their memory was better. And just coincidentally, it was passing by a memory structure, and sure enough, when we did a double-blind trial, these people's memory was better, and that inspired the DBS trial. And that's really kind of part of where my research is going, is that, if we look back 50 years ago, tremor, slowness, stiffness, some of these symptoms were treatable. And so people with Parkinson's disease would end up in a nursing home. I don't know if people have seen the movie Awakenings, but people would just end up basically in an institution because they couldn't move. And then with the advent of levodopa and physical therapies, all of that has changed. And now we're at a point where dementia, where thinking memory problems are the leading reason why people go into nursing homes. And so the hope is that if we could understand, basically the mechanics of thinking memory, that we could do surgical treatments or medical treatments and make that a treatable disorder, even though we can't cure Parkinson's. And if someone cures Parkinson's in the meantime, that's great. I'm happy to go out of business and write grants about it. But in the meantime, I think having another tool in our toolbox to be able to treat that would be hugely helpful.
It's kind of amazing. You talk about how that was accidental. Even DBS itself and the surgery before, that was all accidental. Wasn't there a surgeon doing some work on somebody and accidentally flipped something in the wrong place in the 50s?
Yeah, so there was a surgeon, Cooper, in the 1950s who was doing surgery on somebody with Parkinson's disease and accidentally caused a stroke by cutting an artery. And the artery happened to go to the globus pallidus, which is part of the basal ganglia. And so he, immediately stopped the surgery, closed things up. When the patient woke up, he went into his room to apologize. And the patient said, thanks, my family is doing, so much better. And it, caused this new era in surgery. And actually, surgery for Parkinson's goes back to the 1890s, where when people were initially to treat tremor would actually cut off the motor cortex, which you can imagine, it got rid of the tremor, but it also got rid of any movement of that limb. And I guess the reasoning at the time was that having a still limb that you couldn't do anything with was better than having a shaking limb that you couldn't do anything with. And then surgery kind of fell out of favor, particularly with levodopa, and then it kind of came back in favor as dyskinesia came around, and then in the 90s, DBS, kind of engaged a whole new era of surgery.
Yeah. Okay, interesting.
Speaking of your research, could you talk a little about your meditation research that you did last year?
Yeah, I can't, because I've yet to get any funding for meditation research.
Oh, I'm sorry. Okay, acupuncture.
I did, yeah. Right. I did complete an acupuncture study.
Right.
Yeah, I guess going back to the meditation, I'm planning on submitting a few more grants this year related to it. But I do pretty strongly believe, in large part based on my experience with working with a large number of patients, that mindfulness practices, whether that be prayer, gratitude, meditation, makes a huge difference to people's coping ability, to people's quality of life, and I suspect, and this is what I really want to get a grant to prove, that your mental attitude may actually slow down the progression of the illness, just in the same way that physical exercise, is thought to slow down the progression of the disease. I think that your mental diet and your mental attitude probably plays a big role. And so that's what I'd like to prove with that as of yet, I've not convinced anyone to give me money for that.
Is anyone else doing that research or similar research?
There is a group, and there have been a few case series where people have done mindfulness studies, and there have been qualitative studies, and people found some benefit. And there's a study in Australia that is getting off the ground, I think, right now, that's using mindfulness, but it's combining mindfulness with exercise and a whole bunch of other things. So it's kind of a large lifestyle change program, and that study's off the ground and it's not published. But as far as looking at just pure mindfulness, outside of exercise, outside of anything else, no one's tackled that yet.
Could you explain a little bit about mindfulness?
Sure. So mindfulness, and the resource that I'll usually send people to is a book called Full Catastrophe Living by Kabat-Zinn, Z-I-N-N. And so in that book, yeah, it is a great book, and he outlines a program that they've developed over a number of years, which was originally developed for people with chronic pain, that they found helpful to be found helpful for a number of chronic illnesses, including psychiatric disorders, chronic pain, cancer patients, a whole host of people. MS. Actually, there's been a recent study showing that it's been helpful for MS. And so what it is, it's a program where they teach people mindfulness practices, which are really practices that are meant to increase your awareness of what's happening right now. And they kind of base it on 7 principles. So the principles are acceptance, so being able to accept what's happening, trust, let's see if I can remember all of them.
This is a cognitive task.
Yeah.
It is a cognitive task, yeah. Letting go, what's called beginner's mind, which is kind of approaching things without preconceptions. Non-judgment, and non-striving, trying to get anywhere. And so it's really kind of bringing yourself right into the present moment without resistance and creating a foundation where you can more easily work with things. So part of the idea behind it is that part of the problem with dealing with pain is our resistance to pain. And our resistance to pain doesn't make the pain go away, but it does make it harder to cope with it. And so if we're able to breathe and just, kind of deal with the pain itself and not how we don't want to have pain or anything else like that, it makes it easier to deal with. Yeah, go ahead. I was going to say that other things in the book have to do with breathing exercises. There's some gentle yoga exercises in the book. And one of the things which I think is really valuable about the book is that it's, part of it is trying to make it a daily practice. And so I think, having a daily practice, a daily habit, making a space for yourself to just be, is really invaluable.
It becomes a little bit like strength training would be, but for your mind.
Right. Yeah.
Can I ask a question here? I don't want to. How does that relate to the resilience training of the program that I heard Diane Cook speak about out of Stanford? Did it different?
I'm not familiar with the resilience training, so I can't really comment on that.
Okay.
I noticed that if I am anxious, it makes my symptoms worse. So I've really gotten a lot out of this conversation. I have two questions. One thing that happens when you have Parkinson's is you discover all sorts of things related to your Parkinson's that are not that pleasant, like drooling or a runny nose. Why does that happen, and is there anything we can do about it?
Sure. So we actually have done a series. I've given some talks around town. I think it was called Everything You Wanted to Know About Parkinson's and We're Afraid to Ask. And one of the sections of that was about snot and drool.
It's not a drool. Okay.
And so with regard to the snot issue and, runny nose and stuffy nose, it's not exactly known why that happens in Parkinson's, but it's thought that it may be due to the effects of Parkinson's on the autonomic nervous system, which is kind of the automatic part of our nervous system, which controls things like mucus, saliva, blood pressure, the GI tract. And so, one of the tricks that I've used for people where that's a big problem is that there's Atrovent nasal spray. That seems to work really well for that particular symptom. For drooling, it seems to be a couple things involved. One is that people with Parkinson's don't swallow as frequently. And so sometimes John Dean will talk about this trick about having a sucking candy, or gum can sometimes help remind people to swallow. If that doesn't work, there's also seems to be an excess production of saliva. And so there are some medications that can help reduce the production of saliva. Some of these are oral medications like glycopyrrolate. Others of these are Botox injections or scopolamine patch. Also, atropine eye drops, which we use for glaucoma, can be used in the mouth, and that can sometimes help dry up saliva as well. So those are all different tricks that can be helpful.
What about sweating?
Wait, I want to go back to the drooling. There's more to that, okay? So I know that Dr. Klepetskaya is currently running a study on MyoBlock, which is Botox for drooling. When you have someone coming in, though, Botox probably it's not your first thing, is it? What would you start with?
Right. It's usually not the first thing. The first thing I usually do would be, simple things like sucking candy or, no medication. And then the next thing I'll go through typically is the atropine eye drops, because you can just take it as needed and then it gives you control. Because a lot of times people will vacillate between drooling and dry mouth. And so another thing too is that with some of these other treatments like Botox, it's really important that people maintain good dental hygiene. Because if you don't have enough saliva, then that's bad for your teeth and gums. And so the atropine eye drops can also be a little bit safer.
Have you ever had someone take an anticholinergic medication for the drooling, like Artane or Cogentin or something like that?
Yeah, so sometimes we'll get double benefit. And so in younger people, a medication like Artane that can help dystonia caused by mouth, or amitriptyline that can help with depression and sleep. Sometimes we will use a medication that can have multiple effects. Glycopyrrolate is an anticholinergic that doesn't cross into the brain. The danger with anticholinergics is that they can cause thinking memory problems. And so in general, particularly in people over age 70, I try to avoid that class of medications. But the glycopyrrolate is safe, even in older adults.
And the atropine is as well, because it never crosses. You're giving it to the person under the tongue. Is that why it passes the blood-brain barrier too?
Well, in general, you're giving a low enough dose because you're just doing drops in the mouth that it generally doesn't cause problems, but it would be possible that you could have some thinking memory problems if people are really sensitive to it.
I heard you speaking a while back at Grand Junction, and actually somebody in the audience had a little device that I haven't seen them for a couple of years, but it basically was a little beeper, and it would beep every couple minutes just to remind them to swallow. And it was, you'd think it would be embarrassing, but it's just it goes beep, and then you don't notice it. You're like, what was that? And then 2 minutes later, it beeps again, and I knew what it was once I heard it a couple times. But there is a lot of technology just to remind people. That's all I ever do as a therapist, like just get them to be aware of swallowing more often.
Yeah. A lot of Parkinson's is just about habits, like remembering to swing your arms, remembering to adjust the posture.
That's a great line.
Yeah, it's actually one of the things when I see people with Parkinson's, particularly early on, when I talk to them about it, that I'll tell them that for people without Parkinson's disease, things like a good night's sleep, exercise, diet, all these things are important. But when you have Parkinson's disease, a lot of times they become critical. And so, that it really just puts a lot more pressure on people to develop habits. And some people are, really good at developing habits, and some people are not so good at developing habits. And that's another thing where I think something like mindfulness may be helpful, is that it may provide kind of a gentler way. I mean, me not that I yell at people, but me telling somebody to exercise or to stop smoking or whatever is not typically greatly effective. You know, when people are able to become motivated to do that themselves and they can become, you know, more aware of what their own resistance to doing things is, then it makes it easier for them to make those kinds of changes.
Yeah.
Related to the snot, as you say, what about sweating?
Right. So sweating is also a not uncommon symptom in Parkinson's and relates to the autonomic or automatic part of the nervous system. In some people, it can be a sign of medications wearing off. So sometimes people are having sweating in the middle of the night. It's because their dopamine's running out, or they can have it as an off symptom. And so sometimes addressing dopamine medications can help, but a lot of times it's independent. And then I don't really have, you know, great treatments for it. You know, sometimes people can have a cooler room or air conditioning or stuff like that, but sometimes it can be, you know, kind of an embarrassing thing that we don't have great treatment for.
Right.
You're not going to Botox.
You can do Botox for sweating, and if it's in a focal area, you know, then that would work. But a lot of times people will have kind of like hot flashes or kind of whole body drenching sweat, and that Botox is not going to be so helpful for it. Right. But if it's a focal area, then Botox could help.
Yeah, the hot flashes almost sound like an op thing again.
Well, for women going through menopause and Parkinson's at the same time. Right, exactly.
But you talked a little bit about sleep, and I think, boy, is that a hot topic. I mean, could you talk about sleep dysfunction in Parkinson's?
Yeah, so sleep dysfunction, you know, I kind of divide sleep dysfunction into a couple of branches. So one is sleep problems that are directly related to Parkinson's disease. And so that would include, you know, and actually one of the things I tell people is that Parkinson's is a 24/7 disease, which means that Parkinson's doesn't go to sleep just because you go to sleep. And so if you're undertreated at night, and you're stiff, you're slow, you have tremors, or if you're overtreated at night, that you're having dyskinesias, then Parkinson's can directly affect your sleep. And so managing Parkinson's can be helpful. Non-motor symptoms can affect sleep, so particularly anxiety and depression are oftentimes associated with problems with sleeping. And so if people have a lot of problems going to sleep because their mind's racing, that could be a sign of anxiety. If people are waking up at 3 or 4 a.m. and can't get back to sleep, oftentimes that's a sign of depression. And then people with Parkinson's disease can have sleep disorders. So sleep apnea, where people stop breathing during their sleep or they snore. REM behavior disorder, where people are acting out their dreams. Restless leg syndrome, where people have an uncomfortable sensation in their legs right when they're about to go to sleep and feel like they need to walk around. All of those sleep disorders are more common in Parkinson's, and they all have specific treatments. And so I think the bottom line with sleep is that it's really important to see somebody who knows about sleep rather than just starting a sleeping pill to make sure that you make the right diagnosis and that you treat the sleep disorder correctly rather than just taking so much medication that you get knocked out. Because for some things, for instance, sleep apnea, that can actually make it worse, and it can be dangerous because if you're taking a sedative, then you're more likely to not breathe during the night, and that can make the high blood pressure worse and just kind of exacerbate the problem.
Yeah, and did you talk a little bit about REM sleep behavior disorder as well?
Sure. So REM sleep, rapid eye movement sleep, is the part of sleep where we dream. And in people without Parkinson's disease, what normally happens is that our muscles get unplugged from the brain so that we don't act out our dreams. But in REM behavior disorder, that doesn't happen. And so when people are dreaming about fighting crime, they're kicking and punching. And if they're sleeping next to someone, that somebody might get kicked and punched. Right. Yeah. REM behavior disorder is probably the most predictive of what are called premotor symptoms. And so there's this idea now that Parkinson's disease is a process that probably goes back at least 20 years, if not longer, before people develop symptoms and get a diagnosis, that the changes that are happening at a cellular level are in place for 20 years, and so that people can lose their sense of smell, they can have mood changes, personality changes in thinking memory. And one of the most predictive things is changes in sleep. So people with REM behavior disorder who are acting out dreams have about a 80% chance over 2 years to develop Parkinson's disease or another neurodegenerative illness.
Wow.
And I guess the last thing to say about the REM behavior disorder, which is that it's usually fairly easy to treat. Melatonin can be helpful, and clonazepam can be very helpful in suppressing those movements. And so, and what happens is a lot of times people with REM behavior disorder think they're getting a good night's sleep. They're probably not because of the amount of movement they're making, but their spouse is definitely not getting a good night's sleep. And so sometimes clonazepam will actually help both of them the next day because the patient now feels like they have energy and they're rested because they're getting more restful, high-quality sleep, and then their spouse is also sleeping better because they're not getting kicked and punched.
Yeah.
Getting better.
Just looking at our time, I wanted to talk about your palliative program, but before we do that, Doc, is there anything that you wanted to talk about? You have such an unusual program that I thought it would be good to highlight that at the end here.
Yeah, no, I'm happy to talk about that program, sure.
Yeah, we'll talk about where you got the idea, and you had the very first one in the country, or one of the very first?
Yeah, I think ours was probably the first one in the country. I've actually talked to some people at UCSF who were setting up a similar program. And our program was actually inspired by a similar program at University of Toronto, which has been going on, I think, about 10 years now.
Okay.
And so the inspiration, I guess, backing up, so my training is in behavioral neurology and also movement disorders. And so as a result of that, I end up seeing a lot of patients who have Parkinson's and dementia, people who have multiple systems atrophy, which is a cousin of Parkinson's, which is much more difficult to treat. And a whole host of other disorders that people with Parkinson's really are, should be glad that they don't have. I was increasingly frustrated with not just my inability, but kind of the medical system's inability to help these patients and help their families. That they had reached a point, where, a lot of times the primary care physician, the neurologist, everybody in the medical system says there's nothing more we can do for you. And the things that I saw that really bothered me was that, one is a sense of grief that people were having, in terms of losing parts of their lives. And they, had every right to be upset about it. And it was clearly not depression, but I was just trained to treat depression. I wasn't really trained to help people with their grief. One of the key things for me was talking to a patient who has young onset Huntington's disease, who was having problems with sleeping, and the reason she was having problems with sleeping was because she was afraid of dying in her sleep. And that was a real aha moment for me, because I realized that, I was not going to be able to help her fully, although I actually did help her quite a bit, without having somebody who could help provide some spiritual counseling for her and could help talk to her about death, because even if you're an atheist, that is ultimately a spiritual issue or an issue that comes down to me. And so I guess it's been a year and a half ago now, we started a program with an interdisciplinary team, which I think is critical, where we have a chaplain, we have a psychologist, a social worker, we had an acupuncturist for a time working with us in clinic. Now we refer to her outside of clinic, a nurse, and the 5 of us will work together to help patients and to help their families make it through this journey. And it's a journey that people can make it through with dignity. People can make it through with a lot of control about how they live their life, control about how they die. But they need guidance for it. And they can need help along the way. And so that's really what we set up our clinic to provide. And I can tell you that it's probably the most satisfying thing that I've done clinically, since I've, been in practice. I mean, it's just hugely rewarding to be able to, really offer help to people that, even a few years ago, I would have just, felt bad at the end of the day and sent back to their primary care doctor.
Yeah, that's great, and it must be very rewarding to have started something that hopefully a lot of other places around the country are going to try to pick up on and hopefully replicate to get the word out and help.
Yeah,
go ahead.
I was going to say that we just published a paper in neurology, which people can find online, or I'm happy to send them a copy. It's called, I think it's called Palliative Care Neurology, Time for a Paradigm Shift. And so it really outlines how important, palliative care and supportive care skills are, And I guess to back up, just so everybody knows, that palliative care is really an approach to care where the focus is on relieving suffering for the patient and also for their family. And so that's kind of in distinction to typical chronic care where our focus is really on treating symptoms and maintaining function. And so with palliative care, it's not just about, how is this person walking? It's about their mood, how are they coping with things? Is their caregiver getting burnt out? Do they feel financially secure looking towards the future? Are they getting adequate information? One of the myths that we dispel in this paper is that we think that palliative care is really, potentially useful at any point during the illness. And so we've had people at the time of diagnosis in our clinic who need help with understanding how it's going to impact their lives. Even young people, what do they do about their job? What are they going to do about their children? We've had people going through DBF who've been part of our clinic who need help with extra social support during that process. And then we've had people who we've helped get into hospice and really help them, relieve, some very end-stage advanced terminal symptoms so that they could die at home with their family around them. So it's been a huge spectrum of people that we've helped. And the paper outlines it, and I've actually gotten, starting to get emails related to this paper about people who are interested in kind of setting up similar programs. So I think, 5 or 10 years from now, it's going to be a much more common thing.
That's great.
When do you like to have people come to you for that? I mean, you said it ranges the spectrum. Would you? As a therapist, I like to have people upon diagnosis. Is that a good time to have a consult and talk about what's coming?
Yeah, I think, we're still trying to figure out the best model, but I think a good model would be that, if people are going to a large center like ours, a university setting, that they would meet the palliative care team even at the first visit and just know what we can offer and know that we're there for them. And then as the disease progresses, there may be certain times or transitions where we're more helpful for them. And then, particularly as people advance and get dementia and other problems like that, we might become the primary team that's taking care of them. And so I think we play different roles at different times through illness. But, I would think that, having a setup where we're involved even at the time of diagnosis would be, a good model.
Excellent. Excellent. Betsy, do you have something to close with here? Any closing questions?
Well, we had talked about asking you in the very beginning, did people with Parkinson's ever get better? And, obviously the disease is progressive, so the answer to that is probably not. On the other hand, with all the techniques you're talking about, and particularly your palliative program, people can live better with Parkinson's than 5 years ago, 10 years ago. Mm-hmm. Would you agree with that? Do you have anything to add?
Yeah, well, I would say, I have seen people in my clinic who have gone the opposite direction that we expect. So I've seen people, actually, one person who comes to mind, came into me with young onset Parkinson's disease. He was thinking he was going to have to give up his work, and he has a very highly demanding job, and we were able to get his medications together, and, he's actually in better shape than I am. I think, he really appreciates the kind of second opportunity at life. He's skiing, he's working out, he's doing all these things, and he appreciates it more than he did before he had Parkinson's. And so I've seen people, who are actually, in a lot of ways, some physically and some psychologically, who are actually doing better than they were before they had the diagnosis. That's not typical, but it's not uncommon that people, when you get them on the right medications or with EBS, are really able to live a pretty decent life, and, to the point that people are surprised that they have Parkinson's if and when they tell them.
Mm-hmm.
That's good.
So that's certainly possible. And at the same time, going to the palliative and supportive care clinic, one of the things that's been, again, kind of rewarding to me is just that, that people, even in the last stages, that there are, things that cannot be robbed from a person. And so, people are able to connect with their family, they're able to have a, meaningful exit, they're able to, die with dignity, they're able to not have everything, not go out with the feeling that everything's been taken away from them. and that, that people, everyone's going to die. And I think that was actually part of my inspiration for doing the palliative care as well, was kind of working with, monks in a monastery. And, I think part of my reason for doing this is, one of the things that they told me that I really took to heart was that, in order to help somebody who's dying is that you have to stop pretending that you're somebody who's not dying. And so, by relating to the fact that I'm dying and relating to, my own work with the dying process, I feel like I'm able to, more comfortably just be with somebody and support them through that.
Mm-hmm.
So, there's, a huge spectrum of, how Parkinson's progresses, and, it ranges from people. I have patients who have Parkinson's 30 years who, still work on a ranch, and, and there's, patients who really need our clinic and need hospice. And, it's a pretty wide range of ways that people can, still be themselves despite everything.
That's beautiful.
It is beautiful.
Well, Doctor, I really appreciate you taking some time to talk with us. Always very interesting insights. Well, I guess we'll get this together. We'll put it out on the web, and we'll certainly make sure to include your university email address to contact about the studies that you mentioned. And maybe I'll even try to find a link to, do you have any link that has all the studies that you happen to be doing, or your university program? Are you the director of the Movement Disorder Center?
Yeah, I'm the director of the Movement Disorder Center, and we're in the process. We do have a website that we're getting up and running, and I don't know if all the studies are on there and up to date, but if you email me at the current time, that's probably the best way, and I can let you know if you're eligible for studies and get you in touch with the right people. So we could just do that for now.
That sounds like a great solution.
That's great.
Get it straight from the doctor's mouth.
Right.
All right. Well, thank you for your time, Doc.
Yeah, no problem. You take care.
You too.
You too.